Okay, if I can let's get the committee members up here and let's get started.
Madam Chair, when I was on the call the other day, you said you had bronchitis. I almost fell off my couch. I'm like,
Yep. Not, just,
good morning.
hi. Okay. Okay. Good morning, everybody. It's very nice to see so many people in person, even wearing masks. It was still nice to see you in person, and thank you very much for coming. Can everybody turn their cell phones off? So make sure that they don't ring during the meeting. I'd appreciate that. And we'll get started. Like I say, I want to welcome everybody. Today's hearing on health disparities, which is certainly an important topic. And it's one that the Health Committee routinely looks at, issues on access to care in all aspects of healthcare. And today's meeting is just another example of that. But today we have a special because we brought together experts in the area and people who spend a great deal of time working to increase awareness and access to screening and other services for individuals with chronic diseases, and especially those in underserved areas of our state and those of community of color. And I want to recognize AstraZeneca for the work they have been doing to elevate this conversation in Georgia. Okay, so thank you very much. I look forward to today's discussions from the experts. And, during the 2001 session, Representative Schofield put in and had many co-sponsors, several of which are here, a resolution specifically to address this issue. And while the resolution did not pass, it is important conversation. And that's, like I say, one of the reasons also that we are here today, because although that didn't pass, we still wanted to be able to discuss it. So for right now, I'd like to turn this meeting over to Representative Schofield for some introductory remarks, and then we'll hear from our presenters. Representative Schofield.
Thank you, Madam Chair, and good morning to the members of the committee and invited guests. I'm so pleased to be a part of this conversation today, and I was proud to sponsor House Resolution 188 during the 2021 legislative session, designed to look at this topic very near and dear to my heart as a person that lives with a chronic disease. And we all know that the issues related to health disparities didn't start with the pandemic, but they've been exacerbated by the pandemic. It's crucially important to elevate this conversation and to understand where the gaps are in screening and care, and continue to find ways to impact change and improve health outcomes for these most vulnerable populations. So I thank you for all the members that are here and the subject matter experts that are continuing to do the work in the field. And I hope today's hearing will put a focus on this issue and provide background on not only the great work and the many people and organizations that are making a positive impact, but that we see real sustainable change, because our time is now. So thank you, Madam Chair, and I'll turn it back over to you.
Thank you very much. And I would like to introduce our first speaker, who is Dr. Patrice Harris. Dr. Harris is the past president of the Georgia Psychiatric Physicians Association and immediate past president of the American Medical Association, which is quite an honor. for Dr. Harris and also for our state, for one of our physicians to be the president of AMA. So, Dr. Harris, thank you so much for coming and giving your time to us.
Well, thank you, Chair Cooper, and thank you, Representative Schofield, for bringing us together today. Thank you to all the members of the committee for your commitment to having conversations about these issues. To start, though, I would like to extend my gratitude and a sincere thank you to the physicians, residents, fellows, medical students, nurses, respiratory techs, and other health workers in Georgia, by the way, including those essential workers who have risen to the immense challenges of this pandemic with remarkable and tireless work. It has been extraordinary and at times has come at great personal cost. Unfortunately, many in our health community have died since the beginning of this pandemic, and many more have fallen ill. So I like to start at every moment with gratitude. And so I want to take a moment for gratitude for those, and gratitude again for you all in addressing these issues, because they are not new issues. They are critical issues vital to the health of our state. And I thank you for the opportunity. It's also important to have this opportunity so we can get out the facts and information. Disinformation and misrepresentation erode public confidence in science, in physicians, in elected officials, and undermines trust in all of us just at a time when we need trust most. So I thank you for that opportunity. Certainly, COVID-19 has amplified, again, already existing inequities. Communities of color, as we know, have been hit especially hard by this pandemic. And I'll talk more about the reasons for that later. But in survey after survey, in data point after data point, you see communities of color who are disproportionately impacted with COVID. Now, I guess there is some good news there, and that is we had some data, but the data was incomplete. And so the first thing as we move forward, we will have to make sure that we have a commitment to collecting the data by age, race, ethnicity, gender, zip code, so we can use that data to make sure our interventions are targeted in the right places. You know, I hear a lot, I think all of us hear a lot about data. Data is the new currency. Data is the new oil. I'm not sure. I tend to shy away from hyperbole, but I do know that data is public good. And we've seen that. And if we want to know where the problems are and immediately go to those problems, we do need data. And I think that there will be public-private opportunities to do all that we can to improve our data infrastructure. I think many of you know that I was a health director here in Fulton County for many years, and mental health infrastructure, public health infrastructure has been chronically underfunded for decades. Public health is one of those things that you don't know you need it until you don't have it. And so we certainly need to make sure now. And I do think, though, I just spoke to a group of folks who are working in data in the private sector. And I do think there will be opportunities, as I said, for public-private partnerships. We continue to face significant challenges, again, with COVID, but COVID is the current backdrop against which we can see the results of centuries of inequities. Again, as Representative Schofield said, these are not new. We had disproportionate impact when it came to diabetes and heart disease and some forms of cancer. And if we didn't have a disproportionate impact regarding the actual the actual amounts of disease, we certainly had disproportionate impact as to who, or we should more likely say, did not have access to services. And so we know throughout the last several decades, communities of color have experienced the consequences of structural inequities of healthcare. These inequities, again, are well studied and documented, and what we know is that they are produced and not random, and most certainly avoidable. Many of you have likely heard about some of the reasons why, and we need to think about those reasons. And I like to step back and say, well, what creates health in the first place? We need to talk about not only what detracts from health, but what creates health in the first place. And we all know there are many factors that contribute to whether or not someone is healthy. Yes, whether or not they have affordable, meaningful coverage. Yes, whether or not they have access to a physician, whether or not they have access to a hospital. We know that many folks in rural Georgia live far away from services. And what is the COVID-19 teaching us, among many other things, that even if we have accelerated adoption to telehealth, and I'm going to say a little bit more about that later, not everyone has broadband access. And so that is something that we as a country and as well as a state need to address as we move forward, because it is whether or not you live in poverty. It is education. And again, there's that link there. If you didn't have broadband access, you couldn't get your schoolwork. And we know that education does have an impact on healthcare, lack of employment opportunities. We all want Georgia to be a place where businesses come because they see that they have an educated workforce and a healthy workforce, certainly jobs and housing, insecurity, access to fresh foods and vegetables, and public transportation. And certainly as we look back on history, discriminatory practices have all led to where we are today. I want to say take a moment to say something about trauma. As you all know, I am a child and adolescent psychiatrist. The night I was inaugurated as president of the American Medical Association, I said I wanted to elevate three things in addition to all of the priorities of the AMA. I wanted to make sure that everyone understood the importance of mental health and to overall health care. I wanted to talk about workforce. We need to make sure that we have a prepared workforce, a diverse workforce. Of course, I was specifically talking about physicians, but that is across the board. And we need to make sure we are addressing trauma. And of course, none of us would have wished this pandemic on the world, but what are three issues that have been elevated with this pandemic? The importance of mental health, the importance of, again, diversity in the service of equity, right? Not just as a checkbox, but in the service of making sure that people are healthy, and also trauma. Hopefully, and I'm happy to make sure the committee has information about the ACEs study by Kaiser and CDC regarding adverse childhood experiences and the impact on health, and not just our emotional health, but the development of cancer and diabetes and chronic disease. And this landmark study also found that almost 2/3 of the study participants reported at least one adverse childhood experience, and more than 1 of 5 reported 3. And I know there's some work going on here in Georgia. I've been in some of those conversations, but we have to make sure that we keep that on the forefront. No one knows more than you that sometimes folks have a short attention span. And, I know that we will get through, and we will get through this pandemic, and people will go back to our usual distractions. But we have to keep these issues to the forefront again, which is why I'm so glad you're having this meeting today, issues around health inequities, around mental health and trauma. Now, from time to time, and especially during the pandemic, we've seen some differences, but overall, people from communities of color experience mental health trauma and issues at rates similar to others, but it's the access to mental health services is much lower. And I know there've been lots of conversations about this here in Georgia, but we know that Blacks often receive poor quality of care and lack of access to culturally competent, concordant, culturally humility. I use the terms cultural humility, but it's been reported that only 1 in 3 African Americans who need mental health care receives it. And I'm particularly concerned about the children of these communities and not getting the care. I also will just say a quick word about the opioid epidemic. Many of you also may know that at the AMA, I chaired the AMA task force from 2014 to 2021 when I rotated off the board. And we know that originally this epidemic was mainly about prescriptions. But I have to say, there was a previous epidemic in the 70s and the 80s of opioids. It's a good news that we've pivoted from incarceration to treatment. Now we have to make sure that everyone has equitable access to that treatment. little bit on children. Earlier this year, an article in the Journal of the American Medical Association highlighted concerns about children's mental health during this pandemic. The article argued that COVID-19 has worsened existing mental health problems. I support that argument because of its unique combination of public health crisis, social isolation, and economic recession. I don't need to tell you this. We've seen the impact on our children. Now, I don't want to, some children, by the way, preferred in-person learning. So what we tend to do, I think in this country, all of us, including me, we like to lump things together rather than splitting. And that's why it's important to have that disaggregated data. So clearly, and as a child psychiatrist, I believe in socialization, and we need to find the learning environments that are important for our children to thrive. They are usually not one size fits all, but I would say most children do have the opportunity to thrive in in-person learning. Socialization is important, but I do also want to point out, a lot of my adolescents that I saw in my private practice experienced a lot of bullying. And I have heard stories from many of them that when they were learning from home with all of its challenges, at least they didn't have the challenge of bullying. I've seen a lot of anxiety in my practice. Again, bullying led to that. But we all know that our children today are living in a world that, and I will show my age, we didn't have to worry about. When I made a mistake, only a few people knew about my mistake, but now everyone knows about the mistakes with social media. And, we have a generation of children who do active shooter drills. And so we are living in an age of anxiety, particularly, around our children. And so we do need to make sure. We've seen increased number of suicides. And by the way, disproportionate increased number of suicides in young Black boys. And so we really have to, again, have that data, disaggregate that data, and make sure that we have the services available for everyone. And they are not one size fits all services. What works for one group may not work for another group. So we need to make sure that we are addressing those and getting people the care that they need. I've already talked about the workforce, because I am going to talk about some solutions here, right? It's not just about the problems. Many of you know, and I'll just focus on physicians here, but a lot of residency training spots are funded at the federal level, but states have a great opportunity to add slots, particularly to specialties that are underrepresented, because that's certainly a solution. And of course, it's, protecting the ability for everyone to have care. And we need to think about the future. So what do we need to do? Because what we're doing now is not working. I'm very proud, and I've been very a passionate proponent of integrating mental health care. Because listen, there are not enough of me, and there are not going to be enough of me in the next, I don't know, maybe 20 years, excuse me. And so there are new models of care, and of course, I'm not here representing the AMA, but during my time there, we developed the Behavioral Health Integration Collaborative. But I know at the American Psychiatric Association, they have been proponents of collaborative care, where there are psychiatrists who collaborate with primary care. I know I have some primary care colleagues here, and that's what we really need to do. It's going to take innovation. We've seen telehealth. I just co-founded, I'm the CEO of a digital health company, Care in the Home. We've seen that explode now. There's promise and peril in technology. We have to make sure privacy and confidentiality. I worry a lot about those issues because I see discrimination against folks who have a substance use disorder, but there's no question that there's a lot of promise in technology. We just have to make sure that we use it correctly, and technology doesn't worsen inequities. And so I think I've talked about technology that impact the inequities. I will leave you, and I'll make sure that everyone has a copy. If you have not seen this report, it's by SAMHSA, and it's called Double Jeopardy: COVID-19 and Behavioral Health Disparities for Black and Latino Communities in the U.S. It's a very good study. I'll email it, make sure the chair has a copy. And it also talks about some solutions, and I do like to end on solutions. You can clearly see the problems, but here are just a few solutions as I close. I've already talked about data disaggregation. We need flexibility in treatment policies and payments. I will say that as I work with children, so often I want to make sure that they have good access to care to treat their trauma. And also, by the way, I want them to be able to get preventive care. I don't want to have to put down a diagnosis, but we know in our current system, it is around reimbursement. Now, listen, we have to keep the lights on in our practices, but we also need to, I think, expand how we look at care in this preventive, sort of even a public health way of looking at mental health care, but really looking at care in general. So there's flexibility in treatment policies and payments. Certainly expanded and flexible coverage for telehealth during the pandemic. We were glad that CMS and some commercial payers, not all, relaxed, and there was pay equity with telehealth care and in-person care and even phone visits. I'm originally from West Virginia, and I went back to West Virginia, and I went to a coal mining. I'm from a small town, Bluefield, but I even went down to even smaller towns. And on my way there, I had no bars. It was a little bit scary, I have to tell you, having no bars, and not no bars for a second, and no bars, and maybe I could raise my phone, but no bars for about 30 minutes. And so I talked to some of my physician colleagues there, and they said the telephone was such a blessing there during that time, and they could continue to see their patients with telephone care. So we have to make sure that there's pay equity there. We have to think about communication and how we communicate, health literacy, public awareness, especially regarding mental health care. There's still a lot of stigma. Partnerships are critical with faith communities, certainly with our elected officials and our institutions. We need to, Georgia has great peer navigator. And so I think we need to look at a new cadre of professionals who can be a part of physician-based team-led care. I think that is very important. And finally, when it comes to mental health, we have to make sure that our parity laws are followed. Those laws have been on the books for over a decade. President George W. Bush signed those laws, or signed that legislation into law. But it's up to the state health insurance commissioner, to make sure that all of the commercial insurers are covering parity and making sure they are offering parity. And of course, that's if you have commercial coverage, and then you have to also look at the public mental health system. So thank you very much for your time this morning. And Madam Chair, if I have time, I'll answer questions.
I will say that the state has a long way to go, but we are making progress. We have put money into getting rural broadband out, and have changed our laws to try to help get that access to the people. It's they're beginning to move on that. So I'm proud of that. The speaker has committed to putting more money into mental health in the coming session. So inch by inch, we passed the telemedicine bill, and so that you will know, the phone visits are in there for psychiatrists and people in your field, so that when people don't have broadband, that you can still reach patients through that media. So like I say, it's not over. We have work to do. And I guess that I would say one of the biggest problems that we have is workforce. We are just at the rock bottom in workforce as far as social workers, psychologists, psychiatrists. But I was impressed when I visited a crisis center in Savannah recently. They have 6 residents in psychiatry. They, I think, are all, it's a very diverse group. And most of them said they were staying in Georgia. Let's hope that commitment continues. And they are getting great experience out of that crisis center in Savannah. So I was really glad to visit and to learn of those 6 residents, because I think before we were turning maybe 2 out of our university system. So we're making progress. Representative Mitchell.
Madam Chair, Dr. Harris, once again, thanks for coming by. I've been following your career since you were president of the AMA. You briefly mentioned it, but what does EMED, your company, do?
Yes, so at the very beginning, I was actually president of the AMA at the time. At the very beginning, I was very frustrated with the long lines and people who did not have access to testing, particularly in the very communities that needed the testing. And so I first as an advisor, but then put in some sweat equity as the co-founder and CEO. We brought the rapid antigen test to the home, right? So you don't have to go anywhere for a test, because if you go somewhere for a test, you risk infecting others if you are infectious, or becoming infected if others are. And listen, that is the way I've talked about home diagnostics. This is where we are going in this country. And listen, not everything we won't be able to, but maybe some simple home diagnostics in the home. And so we were able to pre-position, it was the Abbott Binax Now test, but you signed up to our platform and we proctored the test. So we made sure that it was Patrice Harris taking the test and she didn't swab her dog's nose. Because listen, when the stakes are high, when the stakes are low and you just want to know, maybe I'll just have a small dinner party, people I know, and I'll just invite them over and everyone to go to get a test. The stakes are not super low, but if you know these people, but when the stakes are high, as people are returning to work, to schools, you want to know, you want to have the infrastructure and a system. And so we developed the platform and the infrastructure.
And you get the results.
15 minutes.
Yeah. Interesting.
And for your leadership and your service to Georgia. And if you will get those reports to Lynn for me, then we will make sure that everybody on the committee gets a copy. And I look forward to reading them and learning a lot more. Thank you.
Thank you.
Oh, I'm sorry, Representative Fry.
Thank you, Madam Chair. I appreciate you getting us the study, the ACEs study and the one from SAMHSA. That will be very valuable. Would you say that, and we've been hearing a lot about the uptick in crime in our metro areas, and are there any studies that could possibly attribute the uptick in crime to some of the, especially within our juvenile population, some of the stress based around the pandemic and the COVID-19 and how we're seeing our children react to it in more of a violent way or more of an outburst way because of the lack of care and the lack of equity to these services?
I have not seen any studies that sort of connect the dots from the trauma and the stress. We've seen maybe some suicides, more anxiety, trouble learning, but no connection with crime.
All right. And thank you, Dr. Harris. Thank you very much. And moving on, we have Dr. Mack from Morehouse. What? Oh, he's online. Okay. Dr. Mack, welcome. Thank you so much for taking time to be with us today. I want to sing the praises of Morehouse. Y'all are doing a great job on educating future physicians for the state of Georgia who want to do primary care and go out into our more rural communities. I've been really encouraged to see these young people often knocking the socks off their medical exams and really prospering at Morehouse. So thank you very much for all that Morehouse does and for joining us today.
Thank you. And thank you for having us today. Hello to the panel and Dr. Harris. And just want to follow up with the words of Dr. Harris, some of the background that she's talked about, and take you further into the data and some of the work that we're doing at Morehouse School of Medicine. But thank you to the committee for having us today. And if I can, I'll share my screen. And hopefully we can get the committee these slides. And Madam Speaker, can you see my slides?
Yes, sir, we can.
Okay. So I just want to tell you about the COVID-19 pandemic and the impact of minority communities and equitable solutions for health. I want to start on a national level and just drill down to Georgia and just leave you with one solution-based model that we're working with now at Morehouse School of Medicine. As Dr. Harris stated, data is important, but we always want to remember that data is not the human being themselves. Data is the best tracker that we have to follow the actions of humans and what's occurring with them and across this nation. However, data is our best evidence. So we need that evidence in order to see what's happening, survey the health of the community, but also to improve their care. So we know that COVID-19 has been overwhelming and probably the most traumatic disease that has hit this world that we know of. And here are the numbers. And as we go through the numbers, we see in Georgia that we are one of the largest states. We are the 8th most populated state, but we come in number 6 when it comes to COVID-19 cases and across this nation. And this is the World Health Tracker, World COVID Tracker. And this was as of this week that I have these numbers here. So this is the backdrop for the conversation about COVID and what's happening here in Georgia. But Georgia is within a nation and we're not isolated. So what happens in other states affects us, and what happens in Georgia affects other states. So let's look at the numbers. We know when it comes to the different racial and ethnic groups that non-Hispanic whites are mostly affected. And I always tell audiences that there are more whites who are infected by COVID-19 and some of the health-related and health illnesses that we talked about than there are other populations. There are more whites who are getting sick and dying. There are more whites who are poor across this nation. And I say that for a reason. The reason is that health equity affects everybody. When you're sick and someone is dying, you want health and you want access to care. That's whether you're poor or white, you have any other racial or ethnic group, you impoverished, you don't have transportation, et cetera. Those social determinants of health that actually affects our health, our morbidity, and our mortality. So it's so important that we understand that health equity will help the health of all populations within this nation and within the state of Georgia. But let's look at health equity, and let's look at the health diseases in COVID, how it's impacted inequitably those minority populations. And this slide just tells you about the cases when it comes to hospitalizations and also deaths. And we see that the minority populations, American Indian, especially African-American and Hispanic populations, have been heavily hit when it comes to cases, hospitalizations, and deaths across this nation. This is another report that came from the COVID tracker. And this tracker really looked at the data and how we're capturing data across this country. And it shows that Blacks, African-Americans, non-Hispanic Blacks, 1.4 times the rate of white folks when it came to death and dying. And you hear me say folks, and it might make me sound Southern, but I just want you to know I am from Augusta, Georgia. So I lived and breathed. I went to Payne College in Augusta. I left the state and went to Mahara for medical school, but I came back to Morehouse School of Medicine and I trained in here, and I've been practicing in the state of Georgia, not just in Atlanta area, but all across the state in the behavioral health system. I've worked with Dr. Harris before, and I've had the opportunity to do emergency medicine. So I've seen across the state and the impact of health, mental health and physical health. So this is close to my heart when it comes to how COVID and other health illnesses really impact us within this state and across this nation. And when you think about the children, we're seeing that children who have Black children are more highly affected when it comes to COVID. They're dying at a higher rate. We also know that African-American and other minorities, Hispanic kids, they have a higher rate of obesity, diabetes, and hypertension. And this can also be tied back to the social determinants. But in this particular study that was done, the Nature of Public Health Emergency COVID, this was published, and it showed that demographic predictors of hospitalization and mortality were higher among Blacks when it comes to hospitalization for COVID. And then we turn to the vaccination rates. And we've heard the story, but we see that African Americans and Hispanics have lower vaccination rates when it comes to, there are multiple reasons, but access, and also as far as like distribution. We've seen that there've been some inequities across this nation. So let's look at what I want to take away, and I know others would talk about today, is the determinants. This graph shows you that education really accounts for access to care and also your health. It's inextricably related to your health. And the World Health Organization has shown this across this world, that the lower amount of education you have, the less education you have, the worse health outcomes that we have among those population. And this shows that the highest bars you see among each racial and ethnic group are those who are less educated and not those who had the highest rate of mortality from COVID across this nation. And this also applies to Georgia. When we look at education as a social determinant and also access to technology, which was mentioned by Dr. Harris, to the left, it shows that teleworking has fallen significantly over the last years, but remained far greater for workers with higher level education. Those who are educated have higher level of access to technology. We know that the telemedicine gap is the same as the education gap. Those who did not have computers to have education remotely are those same populations who could not have access to work. So they have to get out the house and work. So when you look to the right, you see the demographic groups which had less access to teleworking. So not just education, but also because of your race and your ethnic group can also be at higher risk for the inability to have access to that technology. And another social determinant is also just your occupation. We know that the meat packing industry, the first thing we heard when it came to COVID-19 was the meat packing industry in Texas, where they were dying in a certain area in Texas, northern Texas, because of working around food and agriculture, transportation. Those who are poor, more impoverished, but also less educated usually have the highest risk jobs, which in this case put them at higher risk for COVID-19. But most of these things that I've shown you so far can go across the board to diabetes, hypertension, et cetera. So some of the work we've done at the Morehouse School of Medicine, again, looking at some of the data and some of the science that has been reported, it looks at the variation in reporting of the data. And Dr. Harris, again, looked at this as far as like, how do we collect the data and how are we reporting on that data? So the accuracy of data we know is so important across this nation because data equals resources, equals money and funding in that area. You all know that better than anyone else. But a little history and background of this study shows that disparities are associated with historical inequities and systematic racism has been, some people don't like that word, but whatever you want to call it, it's been going on for years. And if you look at the previous pandemics, minority populations had the worst health going into pandemic, the 1918 flu pandemic, during the pandemic and after the pandemic, the disparities in health actually widened. And that's going on since all pandemics, since that first one. So disproportionate of minorities serve in essential and high exposure positions, as we've shown, and minorities are exposed to inequities. And these are some of the social determinants as we spoke about. But in this study, we showed that the collection and reporting of racial and ethnic data is so important because of the financial implications, but also the accuracy of data is so important to the modeling and the trajectory of illnesses, which helps us to build this healthcare infrastructure. So we need the accurate collection and reporting of data among racial and ethnic populations. This report showed that there are state variations in the reporting of cases and deaths all across this nation. The methods of reporting is unclear. And actually, the missing racial and ethnic data included in Georgia, the identification of those various racial and ethnic groups. There are disparities in that reporting all across this nation, but it's not accurate. And we've gotten better, even within Georgia, but we're still not there where we're always reporting these numbers and we're breaking them down to actually who is more highly affected in other areas. We have to be specific among the racial and ethnic groups because we have so many across this nation and in Georgia. And then again, hopefully we can get to the point where we're reporting on those socioeconomic factors. The second study that we've done is the population level disparities, just showing how just being of a racial and ethnic group, just being brown or Black gives you a higher risk of a health disease. And in this instance, COVID. And this study showed to the left, COVID cases, to the right, it shows deaths from COVID. But just being in those counties where you have higher populations of non-Hispanic Blacks, you had higher incidence of COVID. So basically where there were more Black folks, you have higher incidence of COVID, which means within that population, of course, the racial and ethnic groups are at higher risk for the infection, but also higher risk of deaths. So this map matches up basically with the COVID map that you see when it comes to death. And you look at the Southeast, which traditionally has higher risks of hypertension, diabetes, and those chronic diseases. When you squint your eyes, that's what you see. And that's basically mimics those maps that we've seen in the past. And then when we looked across Georgia, the primary care shortages areas associated with higher COVID rates, we saw that the highest percentage of Black, similar to that national survey, also meant that if you had a higher percentage of Blacks in your COVID, in your county, there was a higher percentage of morbidity and mortality with COVID. So basically, even adjusting for socioeconomic and health system factors, that meant just being Black, you had a higher rate of having COVID-19 hospitalization and dying from that. It also shows that health professional shortage areas has higher rates. And as you know, coming from the National Center of Primary Care, there is important that we continue, as Madam Speaker stated, to recruit and retrain primary care providers within this state and across this nation. So I'm coming to a close, but just want to show you one of the innovative models of support that we're doing at Morehouse School of Medicine, and it's the National COVID-19 Resiliency Network. And we're excited about this, and we know the state is excited about this, but we were awarded a $40 million grant from the Office of Minority Health, and this was a competitive grant. So Georgia won this among all the states in this nation to actually provide a strategic infrastructure to support those minority communities that were highly impacted with COVID-19. And that's all across the nation in every state, territory, and tribe. Basically, the 6 objectives to identify and engage these populations, to nurture and develop a dissemination platform, to disseminate culturally and linguistically appropriate information to these populations to overcome those barriers to care, but also to vaccinations, education, etc. But the number 4, to link them to services. We are to monitor and evaluate the success of this platform, but also disseminate comprehensive and information and best practices, evidence from this collaborative, but share these with the Office of Minority Health, but also with communities and partners across this country. We have multiple partnerships across Georgia, across the nation, and we want to emphasize how important it is to have partnership to develop any models that's going to be successful. You must work within communities and let communities lead these efforts. And these are the minority communities, which we traditionally have not let lead these efforts. And that's what we're attempting to do with this model. We have a website. This information will be left with you that folks can get a subscription to, but also just peruse. And on this website, there are many languages, over 30 languages, 20 to 30 languages that we anticipate of the various communities across the nation, because it has to be culturally and linguistically appropriate for communities to overcome those barriers to vaccination and linking them to services and education. There's a location tracker where you can locate services within your area, whether it be just for healthcare, mental health, vaccination, testing, etc. Education materials online. We're working with community health workers, but also we're doing training for communities. And there is an app. But even if you can't access the app, which some communities can't, you can go on and just have it through the web viewer on your phone. There's a call center, multilingual call center to engage communities. And then of course, social media is involved. So we're doing a lot of web-based outreach to multiple communities in multiple languages among our partners. We have over 400 partners who have engaged, but at least 40 strategic partners who work with us across all those communities. So just a disclaimer, and I will end it there and see if there's time for any questions, Madam Speaker. And thank you all for having us here today.
Well, Dr. Mack, I want to go back to your voice. I don't know that it's terribly Southern, but whatever it is very pleasing to listen to. And so I will be glad to listen to you anytime. And you have certainly given us some important information. And once again, I want to praise the work of Morehouse, often taking students into the medical school that might not have made a high enough score on their MCATs to enter our other medical schools and turning them into fine physicians who do very well on their exams and are on their way to helping communities of need get the primary care they need. So I mean, I am a big supporter of Morehouse. Mercer is also helping, but Morehouse is leading the way on this. Questions from the committee? Wayne Howard, do you have a question? You're online. Wayne?
Yes, I'll start
There
it
we
off.
go. Hey, welcome.
Good morning. Good morning, everyone. First, let me just say hello to my friend, Mr. Dominique Mack, Dr. Mack. Good to see you. And the work that y'all are doing over there at Morehouse, as the chairman has already said. You represent Augusta very well, I
Thank
must
you.
say. My question is, what more can we do to dive into this disparity that we often see, not only in COVID, but in other matters? Have y'all done a study on some of the best outcomes or some of the ways that we can do a better job of attacking this poverty, the low income area where vaccinations are not being done, treatment and all of those things? If you could, I don't, have y'all done any study on that?
Yes, and thank you, Wayne. You're looking good. Good to see you. Good to see you,
You are
sir.
as well.
Good to see you.
Yeah.
Yes, I think this model was built on studies we've done in the past that show, for instance, that partnering with local community really improves the intervention. And I would just say one of the things to your question is, of course, this model is also built because we haven't really come up with a solution across the board that really works. But what I would put forth is that what we've seen with this model is the partnerships, partnering with local communities. And when I say just partnering, not just involving local communities, but providing resources to local communities to implement programs. And that's also scientific programs. We've typically provided funding to the usual suspects. They go into communities, partner with communities, and then they kind of leave. This works on a model where we're trying to help those local communities to sustain in and of themselves, whether it be community health workers in communities or community-based organizations who live and breathe what they do. They actually have the expertise, the understanding, whether it's rural, it could be a rural community. But even within that, we have to make sure that we have those racial and those ethnic representatives involved to develop the model, but also to implement the model. And that also goes to technology. We usually develop technology for the larger community, the Fortune 500 communities, then it's a trickle down effect. Minority, racial and ethnic groups, poor folks have to be in on the development at the front end. So it's a good fit, both racial, ethnically, culturally, linguistically, but also economically. It can be affordable. So I would just say partnering and providing resources to those grassroots organizations.
Thank you.
Thank you. And Howard, I look forward to seeing you on November the 3rd.
I think I look forward to being there.
Well, it's always good to see colleagues and one that has done as well and taken care of themselves as you have in this time. So see you then.
All right.
Thank you, Dr. Mack, for joining us today and for the information that you have given us. Take care.
Thank you for having us. Appreciate it.
Thank you. Okay. Dr. Jacobs, who's the clinical director of the Georgia Primary Care Association, I think that you want to introduce our next speaker and have a few words to say to us. So
I do.
okay.
Yes, thank you so much for having us, Madam Chair and committee. We appreciate you all. I'm going to say just a little bit about community health centers, the FQHCs. You guys already know because you all support us so wonderfully, and we really, really appreciate it. And then I'm going to introduce our presenter. As Madam Chair said, I'm Dr. Teresa Jacobs. I am the medical director for the Georgia Primary Care Association. It is a members service organization that represent all of the FQHCs here in the state of Georgia. There's 34 of them currently, 229 sites. We're in 123 counties in the state of Georgia. We have serviced over 600,000 patients in the last year, and we're very proud of that. We do primary care, so we see adults, we see pediatrics, OBGYN patients. We also have dentistry, behavioral health. Many of our health centers have pharmacies as well. Many of them, believe it or not, are a training ground for medical students, for PAs, for nurse practitioners, and residents as well. We have a number of our health centers that are also in school-based programs. And we greatly, greatly appreciate all of the hard work that all of those staff members are doing throughout the state of Georgia. We also do COVID testing and COVID vaccines as well. I'd like to, yes.
So, wait a minute, you left out something.
What did I leave out?
You see all that, you do all that. And if someone has no money, they're taken in. If someone has $1 or $2 or $5, they're taken in. If they have Medicaid or Medicare, they're taken. You do all of this and do all of those services in a very fine way with extremely good healthcare outcomes.
Absolutely. Thank you so much for
You're
bringing that
welcome.
up. Thank you so much. But yeah, we take all insurance. And then if you're uninsured, we see folks on and by the way, Dr. Mack, I say folks and I say y'all. I was not born here. I was born and raised in Detroit, but 30 plus years here in Georgia. So I say folks and y'all as well. But we see folks on a sliding scale, as well as we have some grant dollars to see folks family planning for free. And so we appreciate all of the help that you all have given us. At this time, I'm going to introduce one of the medical directors of one of those fine community health centers here in Georgia from Macure Health, Dr. Renita Uzzle, who's been a medical director for over 20 years at this particular FQHC. And then she's going to do a presentation. I'll sit here at the table if you guys have some questions for us afterwards.
The platform, welcome.
Thank you. Thank you so much. And good morning to everyone. And thank you for this opportunity. Dr. Jacobs and I have worked together in various capacities, and we first met as residents. And I'm sure everyone in this room knows how compassionate she is, as well as passionate about what she does. And I'm just honored to continue to work for her. And I say work for her because we truly do, but thank you. This PowerPoint presentation will give you an illustration of some of the work that one of the community health centers does here in Metro Atlanta. We are MedCure Health, which means medicine with care. I'll add medicine with compassionate care. We were formerly Oakhurst Medical Centers, so I don't know if you're more familiar with that name. So again, MedCure Health, formerly Oakhurst Medical Centers, we were established in 1980 in the Oakhurst community, and the healthcare facility was actually started in the basement of Oakhurst Presbyterian Church, which still exists. We are a federally qualified health center providing accessible, quality, affordable, culturally sensitive, comprehensive health cares to the residents of Fulton, DeKalb, and Rockdale counties. And as Dr. Mack said earlier, being culturally sensitive and providing culturally sensitive care is very important in the delivery of care and health outcomes. Our mission, as stated here, but our vision is leading people to healthy lifestyles and improve health outcomes. Our value statements and our core values and what we come to work every day and deliver our core values to not only our patients, but to each other, include respect, compassion, integrity, accountability, excellence, dignity, and affordability. The healthcare services that we do provide: family medicine, pediatrics, OBGYN, dental, ophthalmology, podiatry, behavioral health, gastroenterology, and infectious diseases. So we do provide a wide range of services, and really proud of the growth of particularly our behavioral health department. Our service area, as Dr. Mack mentioned, Health professional shortage areas, we do have a number of them. For our service area of all of the counties that I mentioned, 33% live on incomes below the 200% of the federal poverty guidelines, and nearly 16% of the residents live on incomes below 100% of the federal poverty guidelines. As we mentioned before, there is a shortage of primary care providers, and workforce is what we definitely need to address. The population to one full-time equivalent primary care, the ratio for our service area is 946 to 1, and the national ratio is 638 to 1. For unique health disparities that are governed by the physical and social environment, as Dr. Harris outlined earlier. For our service area, nearly 28% of our service area residents experience low access to healthy food versus 22% for the national average. For those individuals who are 25 years and older, nearly 30% have not continued their education beyond high school. So low literacy is strongly correlated with poor health outcomes. For the physical environment for our service area, there is limited access to parks, green spaces, walkable and bikeable neighborhoods, which does impact health and well-being. So the population that we serve, this is an illustration of how much we've grown over the years. For our users or patients, in 2018, we served 25,149 patients, and last year we exploded to 35,391, and that was most attributable to the patients that we served during the pandemic. And of the visits or the encounters, the number of times people rotated through our doors, in 2018, 59,560 visits, and in 2020, 78,858. And you could see of that 78,858, how many were clinical visits and how many were virtual visits. Now, we were fortunate enough to pivot very quickly when the pandemic did strike us in March of 2020. As you heard earlier, there were some other community health centers that did struggle because of internet access, but you could see the impact of how we were able to continue to serve our population through virtual visits. And the information here from January through July, so we continue to grow. Illness burden and the illnesses that affect our population. As you'll see, the top 3 diagnoses over the last 3 years: hypertension, overweight, obesity, and diabetes mellitus. If you hear in the news every day about chronic diseases, these, I think, are the top 3 across the nation. But what you'll also see is in 2019 and 2020, number 4, 5, and 6 for our population did fall under the umbrella of behavioral health. One of the health indicators under chronic disease for hypertension, for our population, the number of individuals that are controlled. Our goal is, hopefully 53% and above, but you'll see in 2020, due to the pandemic, that decreased down to 39%. And that was most attributable to the virtual visits in which people weren't able to come in and have their blood pressure taken or their hemoglobin A1Cs for diabetes checked. But we did our best to distribute blood pressure cuffs and also some other modalities to help with this. But it's still a struggle. And at the bottom of this slide, you'll see of this population with hypertension between 2018 and 2020. In 2018, 4771 hypertensive patients, and in 2020, increasing to 7537. So now serving these number of patients that have increased, and our infrastructure is still the same regarding our workforce. Those with diabetes, those individuals who have a hemoglobin A1C, which is a measurement of the control of diabetes, the number that you would like to see is 7 or less. For those individuals who are greater than 9 or who were not able to come in for a test at all, the percentages here are outlined. And as you see, the impact of 2020 with the pandemic in 2018, 36%, and even 2019 decreased that number. The lower the number, the better. And our goal for 2020 was less than 36%, given the impact of COVID. And however, that was very high at nearly 49%. And you'll see in 2019 how we compared to the state and the national. And for our center, we were very close to the state. So regarding this state work group that we'd like to support in the initiatives, primarily in the outreach arena. So increasing chronic disease screenings and chronic disease information. Information is important. And as all of us have delivered information to you, the social determinants that we do have to address. And we can address these through case management, also through our healthcare facilities and having case management there. Our case management teams serve as a healthcare extender and support. We do a lot of health fairs and getting the information out to our communities and other community events. So again, thank you for the opportunity and having us come before you. And we hope that we continue to have your support, and I look forward to working with the state work group. Thank you.
Well, thank you so much for all you do, and for the long-running clinic that has done a lot in that community for many, many years. Dr. Mack brought up something, and when you said collaboration on case management, it seemed like to me that years ago, I attended a meeting and it was talking about getting patients back to return visits for very debilitating diseases, and that they found that by training people with no medical background, particularly in communities, from that community to be the contact of providing information, of doing follow-ups and encouragement, was extremely successful. And I think that that's what Dr. Mack was getting at. Am I correct?
It appears so, yes.
I mean, and it's being played out with our addictive diseases already. I mean, like Northeast Georgia Medical Group has people that have had addiction problems themselves in the up in the delivery areas to work with mothers that have been addicted, and in the emergency room. So it seems like that somehow we're missing not to support programs that would develop this kind of community outreach. And
Right.
would you like to add something, Dr. Jacobs?
Yeah, I'll add, Morehouse actually teamed up with one of the community health centers, West End, which is now Family Health Centers of Georgia, years ago. And they had peer-led community health workers that actually went out to folks' homes, and they had sessions at the health center about diabetes. And what they did, they taught them how to check their blood sugars, how to know about all of their medications, and set up little reminders on some of their phones on how to make sure that they kept their appointments. They talked to the pharmacists about any interactions with over-the-counter medications. And that program, even though the funding is gone, it is still sustainable. And those diabetics that were in that program are still doing well. And this is years later. So you're absolutely right. They don't have to have a level of, a degree in order to do this, because it's been shown that peer-led community health workers are very effective in the community.
I mean, it just seems
Very
like
much
that
so.
we're dropping the ball in not trying to help develop in the communities that need it so badly, where we have such disparity, that kind of peer left, and I couldn't find the word a while ago. Thank you very much for that. Support, since it has been proven to be effective and long lasting, even with very little support. So thank you. And I just can't thank our health centers enough. You are our safety net across with 229 locations in our areas where we don't have enough physicians. I mean, y'all have just done the yeoman's work, and I can't thank you enough for that. We have questions from anybody of the committee? Okay. Representative Lott?
Thank you both very much for coming here. It's greatly appreciated. And the FQHCs in the state of Georgia have done a fantastic job. So we're very excited about it. I'm from the Augusta area. So we have Christ Community Health Center there that's done a fantastic job. Physical therapy was added recently to ours as well. So I know you've got this long list of things that you do, and we're very proud of them. So I really appreciate it. I have a couple questions. One is, and this is sort of a loaded question, there's no doubt. So over the years, you know, the reimbursement rates for primary care physicians are pitiful, sad, really. And so I know that you take private insurance, and of course you have your sliding scales, but what can we do and how can we change this? Because when we talk about basically devaluing, I'm moving away from the patients now and I'm moving into the providers here. I think we devalue our primary care physicians with their reimbursement rates. I think it's a national thing. It starts with our Medicare, Medicaid. It goes right on into all the private insurances. One person or one division makes a move, they all follow suit. Mm-hmm. You clearly stated that we have a provider issue. It's everywhere, not just in our FQHCs. Do you know of any efforts being made? How can we help? And how can we unify as a state to try to get folks to recognize that our primary care physicians are really the frontline healthcare providers, and it's going to stop all of this stuff later, or at least slow it?
Sure. I think as we transition from volume-based care to value-based care, and once the data is collected in that arena of value-based care, then we could start transitioning to what the value is of the value-based care. Now, for community health centers or FQHCs, we're a little unique in our reimbursement from Medicaid versus the private sector. And because we are specifically empowered to serve the underserved and underinsured, that's why our reimbursement is a little bit different. However, with the workforce, we still struggle with that because we're not able to compensate our providers as well as other sectors, and everybody's competing for that same pool. One thing I am particularly proud of at our health center is that we've had really good retention for our providers. However, for the support staff, that's a different story because of the competition that's going on. But to answer your question, I think there will be some transformational change as we transform into value-based care versus volume.
Thank you. I appreciate that. Thank you for all you do.
Thank you.
That was a good question. I think one of the ways that I'm not sure that we're going to up the salary, but I think places like Mercer and Morehouse, who have an emphasis on rural healthcare and primary care, and their screening of their applicants to commitment to that will, right. and knowing, you know, and giving them the experiences in rural healthcare and knowing what they're facing. I think we're seeing an increase in people willing to go forward, even knowing what the reimbursement rates are and that they'll be dealing with a great deal of Medicare and Medicaid. And it's sort of a human commitment, this, how the student going into these programs look at medicine and what they expect medicine to give back to them, rather than the high salary of perhaps an interventional cardiologist, but the satisfaction of helping people in need. I mean, I can, having met with some of the students, I can see the differences in talking to them about how they interview and all.
One of the other things too that does help with workforce is loan repayment programs. We have the National Health Service Corps, which is a federally funded. I'm not sure of the programs that are at the state level, but it certainly would help with loan repayment. I think there are some programs at the state level, but that does help recruit. My career path, never would I have thought that I've spent my entire career at a federally qualified health center. When I graduated from residency, my plan was to work at a federally qualified health center for 1 year and then join a lucrative practice in Buckhead. But so two things happened. Two things happened. I started the second center and now we're 9 centers, but that compassion and the passion and every day being able to leave work and say that you've impacted someone's life and health, whether they listen to you or not, at least you gave them the information. Mm-hmm. And then the loan repayment came through, which we jokingly say those are the golden handcuffs. So when my accountant ran the numbers and said, I think you might want to consider staying a little longer, you'll save $80,000 in interest on your student loans. And then the rest is history. So never would I've thought that, I would have stayed nearly 21 years, but even after the loans were paid, et cetera, and then it's a culture too that you invest in.
The state does have a loan forgiveness program, but there is no way that the state can compete with the one that you have for the federal program. And but thank goodness for that, because of those loan replacement, you've been able to staff with physicians at your clinics across our state when we couldn't attract people to do it. So I'm just thankful for wherever the money came from, and the fact that the federal loan repayment is much more generous than what the state can give. Representative Mitchell.
Madam Chair, I think I have a solution, particularly to the funding issues. I'm going to make a motion that we expand Medicaid in this state.
Representative Mitchell, that won't particularly help the physicians in their funding for their salaries. Representative Schofield, and well, right, to get a little more money so you can pay them a little bit more. Okay. I mean directly. It doesn't help that way.
All right.
Right.
Thank you for the opportunity.
Representative Schofield.
Oh, yes.
Thank you for a great presentation. I just want to note for the record that everything you're asking for is in House Bill 442 about your, it's the retention recruitment is a grant program for the rural Georgia as well as all your physicians. This is the bill that didn't get heard, but it's House Bill 442.
442. Thank you. Wow. Appreciate that.
Okay. Representative Lott.
I'm sorry, coming back again. I would like to say that Georgia did have legislation that passed and the governor signed it. It was the Medicaid waiver program that expanded the opportunities for all Georgians to have the opportunity for healthcare. So that's fantastic. So we've really already done that. But secondly, in my original question, was that there has been this narrative, no care in Georgia, that the poor can't get service.
It's not true.
And so often, I hear that and I get really frustrated. I know I've said that here many times, but because our FQHCs are available. And I think sometimes, I know that I feel this way, and I don't know if you all feel this way, but in our communities, we want so desperately, we've focused so long here, at least at the state level. And again, so I'm living in my bubble now. Yes. At the state level, I hear over and over, we cannot provide healthcare to our poorer communities. Well, I live where we have Augusta University. I know they send physicians around the state of Georgia to work even in, some poor communities, of course. And we've got our FQHCs in Augusta as well. I feel sometimes like, because we want to talk about the fact that it doesn't exist, that we forget to mention you all.
Absolutely.
Do you sometimes get a little frustrated? Because I do.
Yes. There's a saying that FQHCs are the best kept secret, and that's unfortunate. And still, even my family, they don't even know. And it's like, well, what do you guys think I've been doing for the last 20 years? Right. I mean, family members, well, I can't do this because I don't have insurance. And it's just amazing. So we probably need to do a better job in advertising somehow, but
Yeah.
we hope that the word of mouth gets around. And then the concept too, I hate to say, people look at, how should I say, they want something free. And the one thing that we can't provide is free care, because we don't have a waiver from Georgia Power to pay, the light bill and all the other utilities, et cetera. And also, when there is payment associated with any product, you hope that there is participation when you do get that product. So yes, I think we do need to do a better job in getting out there and spreading the word.
And I apologize. I did not mean that you all were not doing your jobs. You work very hard.
No.
Very hard all day
received it.
long. I think that we need to do a better job.
I mean, Representative Mike, you bring up a good point, because I think that Becky Riles, their lobbyist here at the Capitol, and I've had several conversations that there is really no money in their budget for advertising to let people know. And even though we talk about it in committee, and I'm over and over every time I get the chance, I think, that perhaps we don't do as much as individual legislators to let people know. And when you say there's no free service, I mean, the sliding scale is so low at times in the below $10, $1, that it's almost free, but there is something that the person has skin in the game, I guess, is what they say, to be involved in their healthcare. But if you can figure out a way to help me get all our legislators to be more active about singing their praises, I'll be glad to do it. I mean, we've passed out the maps, we talked about it to help them, because they have no budget for advertising. Representative Bennett. Is she on?
Good morning, everyone, and good morning, Madam Chair.
Oh,
Thank
Representative
you
Fry,
so
sorry.
much. Yes, I'm on.
Thank you, Madam Chair. I gotta give a shout out to my local FQHC. I mean, they are amazing. The Athens Neighborhood Health Center during COVID, we built a mobile clinic and went around, did an incredible job of getting into the communities that wouldn't necessarily either have the time, the transportation, or the willingness because of different factors, social factors, to go get tested. They did an incredible job. But I do want to point out, though, you look at the map and you see Clark as number 24, but look at number 8. I want to make sure that people understand, I don't think that you have a building in every single county. And especially down in number 4, also, people have to drive very large distances in order to get to you. So it doesn't necessarily, the map doesn't necessarily show the true sense of the coverage, because if you have to drive 2 counties over just to go get a checkup or a COVID test, that's still an issue that the state needs to step in and address. Thank you for your work. And Madam Chair, I do have a question about our loan repayment programs at the state level. If anybody knows if we are maximizing those, do we hit our cap every year?
No. And I don't know. We used to have one. I know that one of them we changed. We had a ridiculous thing for students, medical students, which said they had to choose what specialty they were going in their very first year of medical school. And if they reneged on the scholarship, they had to pay it back by 3 times of what they had borrowed. And I mean, thank goodness we came to our senses a few years ago and decided not to give the loans there, but to give them, I think we concentrate on residents.
Yes.
But I'm not sure that I don't know what percentage that we have take up those things.
A follow-up. Who is the department that's in charge of overseeing our loan repayment?
Oh, it's
Do we know?
What workforce? A healthcare workforce. And so they do it. So you can probably find the information there. Or
And that's in
I can
DPH,
try
I
to-
guess, right?
Pardon?
That's in DPH.
Becky is in a department of.
It's administratively attached to the Department of Community Health.
community
Okay.
health.
Thank
It
you.
used to be the Physician Workforce Board, it was recently changed to the Healthcare Workforce.
Board. Okay,
If we can follow up afterwards, I'd love to get that
Okay.
info. Thank you, ma'am. Thank you, Madam Chair.
thank you. And I think, was it last year that the state helped fund Becky, a couple more sites. Was it last year that we actually, on the state level, helped fund 2 new centers, right?
Each year for the last 20 years or so.
That we've helped fund a couple of them. And of course, we do need more, but we have been participating in helping fund them. Representative Bennett.
Good morning, Madam Chair. I am always delighted to work with you, and I am so excited to hear that you are bringing the federal qualified health centers again to the forefront of our attention. I am most supportive of you and helping you to share this information with our legislators. I am House District 94, and I am akin or close to Oakhurst Medical Center and have used them extensively. They have come into my district and have supported both COVID and even going back to several health initiatives. What I want to do is go back to House Bill 442 and just ask if you could go back and take a look at it, because it has a lot of the things that we are talking about today. I'm a signer on that bill along with Representative Schofield. And if we could just go back and look at some of the things that are in there in that House bill and just talk again and move forward. But I am most supportive of you. I want to thank you. You are always at the forefront of our federal qualified health centers, and yay, Madam Chair. Thank you.
Representative Bennett, my door is open and I'll be glad to look at House Bill 442.
Thank you.
Thank you. Thank you. You're more than welcome. Thank you very much for your presentation.
Thank you.
And being with us today. Thank you to both of you. Okay, one of our former colleagues, Representative Mosby, are you ready? And so you are now a board member with HEAL Collaboration, a patient advocacy organization. Well, it's good to catch up with you and to learn what you're doing. Okay.
This is gonna be great. So I'd like to say, first of all, good morning and thank you. It's great to be here on this side of the this side of the desk. You guys do important work for our community, but I would like to tell all of the people sitting behind me in any advocacy organization that the most important person here is Betsy Howerton. They need to know her.
I would agree with that. So.
So yes, I am here. I could actually be here on behalf of Grady, but I think that what we do, the nonprofit that I helped co-found, we do work all over the country, has bearing here as well. Plus, I didn't want us to get into a scope of practice conversation because I thought that's where this was going to go. But anyway, that's another story. So when I spent 16 years in this body with you all, doing the yeoman's work to help make this state the great state that it is. And when I left here, and I spent over 2.5 decades at Grady, and said, you know what, to have this knowledge and work in this space shouldn't go to waste. So I partnered with a friend of mine who is a CEO of a hospital and another gentleman that's huge in the clinical trial space, that we can do something about the health disparity issue in communities of color. And so we went out actually to try to build an organization that would, I guess, bring more thought and more opportunities around clinical trials in communities of color, because we know that those numbers are dismal. But what we found out when we started this approach, we found out that there was a big gap in education around these chronic disease issues in communities of color. And we kind of pivoted our organization to go after, let's educate the community first. You can't really bring in a new innovative therapy on lupus if you don't know what lupus is and you don't know that you have it. In a lot of ways, a lot of these diseases are misdiagnosed, and because people don't know and they don't know how to advocate for themselves. So we pivoted our organization. We decided that we would go after trying to bring education to the community. There's a lot of misinformation and a lot of mistrust in the community around healthcare. And so we decided that we would approach the most trusted voice in communities of color right now, and that is the church. And we've worked with ministries all over this country to bring this healthcare information. And what we found is that the church is a willing partner to be in the space. They want to be a part of this. We just heard testimony about peer education. This is a place where you can actually have that type of collaboration between the community and healthcare providers to ensure that this information and individuals get to the right level of care. What we've found is that healthcare is very much nuanced. And what we wanted to do was make sure that we build trust in the healthcare system between these communities and the information that's being provided. We also wanted to ensure that we heard from the community. What we were hearing is that the faith community actually has a level of distrust in the healthcare system as well. And so we wanted to kind of build a bridge there and mend that trust. And we found out that when you bring providers or subject matter experts to the faith-based community and they build partnerships, we can actually do better with delivering information to our communities to make sure that they are healthy. The church, in a lot of ways, they are first responders. And we don't look at them that way, but they are. They are the first line of help that people go to when they don't know where to go, when they don't know what's going on in their lives. And I know that, you know, as policymakers, the separation between church and state here, but there are things that we can do collectively as a state and working with our faith-based partners to ensure that we bring programs to those communities through the faith community to ensure that information and services are done in a way that individuals can take advantage of. What we would like to have from you, Representative Fry, it's all on you. Now, what we'd like to have from you is that we know that healthcare, we know that nutrition, we know that fitness, we know that all the different things about being healthy starts with a healthy lifestyle. But we also know that education is the key. And in a lot of ways, education is, and we've heard it from the previous presenters here, that education is huge here. And in a lot of ways, we've done a disservice between healthcare and education. We need to probably look at education like we look at pre-K. So if you look at pre-K, we know that kids do well when they are taught. When they're given pre-K, they do well in the educational system. I heard a gentleman tell me the other day that kids represent 20% of the population, but 100% of our future. And if you think about trying to bend the curve on healthcare costs, because healthcare CPI is probably one of the highest in our nation, that if we look at trying to provide education starting early as kindergarten and moving that forward, that would do more to help cut or curtail the healthcare cost over time. But we also know that there are important needs right now. And we know that these communities need help. They need your support. The faith community needs your support. You're going to hear from Dr. Harris in a minute. I'm sorry, Marlon Harris from New Life, because there's a lot of Harrises here that are representing some stuff. So I just want to make sure I get the right one there. But you hear from Marlon Harris from New Life, and they're going to tell you about the work that they've been doing in the communities and the struggles that they face in doing this kind of work. And so we're here to be that voice. Our organization provides kind of a bridge of knowledge to these ministries and to these communities through the faith-based community, so that our communities get accurate information. We would like for you all to be be our partners in this. We want to see more support, more help from you all, and anything that you can do to support our communities and getting access to this information. We stand ready to be your partner in that. And with that, I know I'm trying to not take a lot of your time, but I just would like to answer any questions that you may have. Take any ribbing that you might have. Also, I had a presentation I was going to present, but Travis, Lindsay, he lost it. And I just want you to get him. No, I'm just kidding.
Yeah. Okay. Who we got? Oh, okay. Representative Fry.
Thank you, Madam Chair. Howard, great to see you as always. Love to see your smiling face. Never saw you frown once in the 8 years we served together. I've got a question. Would you say that the advocacy that your organization is doing through the faith-based organizations is helping out with the mistrust in government and the vaccine hesitancy within the minority community?
So what we're seeing, okay, to answer your question directly, yes. What we're seeing with COVID is an exacerbation, and I think Dr. Harris said that in her presentation, it's an exacerbation of what actually is happening. You see that this mistrust is being played out in how the vaccine rollouts have happened. The church has stood up in many communities to say, hey, get the vaccine, come to us to get the vaccine. And you've seen large swaths of people come through and they become vaccinated through that. But that also opens the door for the church to take some level of criticism. So they have a thin line or a line that they have to walk to make sure that what they are putting out, that they understand and they trust as well. A lot of times we see the church as a place where we just say, hey, pastor, won't you come and do this thing with us? But we don't try to educate the pastor on this is why this is important. And I think that during this process, the church is also learning how to be great in this space as well.
Thank you, my friend. First of all, let me just commend you on all of the work that you've been doing in the community. I've worked together on a number of projects, from lupus, sickle cell, diabetes, everything across the spectrum. So
I got another one for you, actually.
Okay, well, I'm gonna turn my mic off now. All right. We've had conversations before about health ministry in particular within the church. And so this is an opportunity from the state side as well as from the research side that I feel like, and Pastor Harris is probably gonna come back at me on this one, but I really feel like we need to do a better job of understanding, defining the power of and the influence of health ministries within church. It's an under-tapped resource. And I just ran out of time because we did, and it was COVID, we scheduled a training session to have look at how do we train really to maximize churches' resources when it comes to health ministry. There's data collection elements that we should be doing in communities of color through the church. And so I think we do have an opportunity through this piece of legislation, but also resources from the state. If we really truly are trying to address health disparities, and where we spend a majority of our time is in communities, in faith-based communities, then we've got to give them the resources and the tools. But it also means that churches have to be open and looking at what we really need in a health ministry as opposed to what we're getting. So I think you know what I'm saying.
You are speaking my language. You're absolutely correct. And I think that and we're not gonna beat up on Pastor Harris, but he actually gets it. He gets it. That's right. You need no, you're absolutely right. We have to, so let's talk about screenings, because screenings are important. And this is something that I think that will help identify the data that Dr. Uzzell talked about that we need to get. But the church would be a great place to have screenings done for different chronic diseases. There are people sitting in congregations right now that don't know they have lung cancer. They don't know that they have diabetes. And so you can uncover a lot through the screening process, but the church has to be open to that. The days of the mother of the church being with the nurse outfit on, those days they're over. You really do need true nurses partnering with the church to help bring out this information with the congregation. The church does have to be open to that. You're absolutely right. And get them when you get up there.
Okay. Okay, that's the end of the questions, Howard, but thank you very much for coming and for the work you're doing.
No, thank you. And thank you all for the work that you guys do. I miss you. I miss
Yeah.
Betsy more.
So, go to your room.
That's right.
Okay. Ms. Dorsey, who's coming? You're with the Center for Black Women's Wellness, a patient advocacy organizations. Thank you very much for joining us today.
I do have a presentation, so I'm trying to figure out if I should stand here or sit there. I'm going to see if I can use the, oh, awesome. Okay.
Go ahead.
Yes, Madam
You've
Chair,
got the
and to
floor.
the entire HHS committee, thank you so much for having me here today. My name is Jamie Dorsey, and I'm privileged to serve as the CEO for the Center for Black Women's Wellness. We are an important resource for healthcare services, education, and support for underserved women. I also serve on the advisory board for the Georgia Charitable Care Network, with the membership organization for free and charitable clinics in Georgia. And collectively, member clinics serve over 500,000 patients in Georgia last year. So free and charitable clinics play an important role, and community-based organizations play an important role in combination with federally qualified health centers, with faith-based organizations, and the entire safety net network. A little bit about the Center for Black Women's Wellness. We are a community-based organization. As I said, we've been around for over 30 years. We're located just around a mile or two southwest of here. So we're your neighbors. And we serve women and families, and our goal and our mission is to improve the health and well-being of underserved Black women and their families, and to advance health equity. And while CBWW serves individuals regardless of race, ethnicity, and gender, 97% of those who we serve identify as Black or African American, and 85% of those who we serve identify as female. With that said, we are a trusted resource, and we partner with the community to plan and execute impactful programming to address health disparities. We look at health very broadly, and this slide kind of shows you the scope and how we look at health very comprehensively, because no one operates in the silos, especially women. We bring our whole selves to the table. And so we look at improving physical and mental health. We look at improving maternal and child health, and also improving economic well-being. And we serve over 3,000 individuals annually. So we've talked a lot today about the social determinants of health. And so we know that, for instance, as impactful as programming needs to be, that there are so many other parts of the equation. Healthcare makes up around 20%, right, of the health outcomes that we experience. But socioeconomic factors such as food insecurity and housing instability, transportation barriers, education, lack of insurance, employment, that accounts for around 40% of health outcomes. So we have to look at all of this, as important as the healthcare system is. And we've got a great healthcare system. It could always be improved upon, but we should be proud of our healthcare system. But there's also these social determinants of health that have to be addressed to improve health and well-being for everyone. And as Dr. Harris said earlier, improving and advancing health equity helps everyone. So we also know that there's access to care issues. I mean, this map kind of highlights these issues. I mean, we know that transportation is a barrier even in urban areas. And there are even these notions of like psychological barriers, people who've been mistreated by the healthcare system. So they may live in close proximity, but they don't go to seek healthcare. But if you look at the issues of rural health and in many counties in Georgia, like for example, this map shows that there are 93 rural counties in Georgia that have no hospital with a labor and delivery unit. And what are the implications of that? You'll hear throughout, I'm very passionate about maternal and infant health, so I'm gonna be talking about that a lot. But so we have to talk about these access issues, these infrastructure issues, these systemic issues, these barriers. 2/3 of rural births are outside of a woman's home county. What are the implications of this? So in terms of health disparities, we've talked a lot about them. And again, I'll kind of talk about maternal and infant health as an example, because unfortunately, Black women are so disproportionately impacted by so many health disparities, but certainly maternal health is one of them. And we all know, and there's been such attention brought to this issue, including with this committee, that Black women are 3 to 4 times more likely to die due to a pregnancy-related death. We also know that Georgia is among the highest with the most racially disparate rates of maternal and infant mortality in the nation. And then just as I talked about social determinants of health and things like income and education, that in terms of Black maternal health, your income nor your education, it's not a protective factor, right? So regardless of your income, regardless of your education, a Black woman with a college degree is still more likely to die for a pregnancy-related death than a white woman with no high school diploma. So there are other issues beyond just income and education, as important as those issues are. So we have to bring attention to these pressing issues that are driving disparities, unequal treatment, stress due to racism, systemic and structural barriers to access and care. So I also want to talk a little bit about, of course, the impacts of COVID. We've all been impacted by COVID one way or the other, but we know that COVID has resulted in terms of the women that we serve, that there's been delays in seeking preventive care. I mean, there have been decreases in seeking preventive care for a number of reasons, right? We know that many have just delayed getting medical care because in the beginning of COVID, folks were isolating. There may have been fear of going out, of going to seek preventive care. Preventive care is always one of those hard things anyway. If people are hurting or burning or anything else, they're going to go to the emergency room. But so often people don't seek preventive care. There's also the issue of increased stress and depression and trauma because of COVID, that oftentimes because of what's happening with you mentally and emotionally, that is going to be a deterrent to seeking preventive health care. And then also for women, especially, there are issues such as, you know, the impacts of being a caregiver and dealing with virtual school and all other kinds of reasons why you're not going to be taking care of yourself because you're just taking care of others. And those issues became more prominent because of COVID. And then finally, of course, essential needs. In the beginning of the pandemic, there were just pressing needs that people had, which is why oftentimes they didn't seek preventive care. So what did we do as an organization? In the beginning of the pandemic, we actually applied for funding specific around COVID relief. We felt that because we were a trusted resource, that it was important to be not only a safety net as it related to healthcare, but we also wanted to meet people and address the need at the time. We converted all of our healthcare services to telehealth at the time. And so we were able to still provide continuity of care for those who needed it most. We began providing home monitoring supplies so that people could monitor their blood pressure, diabetes, and things at home and help facilitate telehealth. We also began doing virtual health education. We increased mobile mammography services, and we expanded mental health services through partner agencies because we, of course, as you all know, mental health increased substantially because of COVID. We were also able to provide, as I said before, some direct relief to address essential needs. And so we were able to do some rent and mortgage assistance, utility assistance. We're providing grocery gift cards, and this was essential. We were proud of this work, not happy to have to do it because of the, why we had to do it, but we were really, really so grateful to be able to do that. And so going back to like those social determinants of health, these were some of the things that we did. We did assessments, and we were asking about the sense of security. And so for the over 300 individuals and families that were served through our COVID relief project, or almost 3/4 of them worried about stable housing in the next 2 months. So again, let's talk about this issues of housing instability. Around 2/3 of them reported electricity, gas, or water was threatened to be cut off. We had around 43% who needed to seek healthcare but could not because of money. And then we had over half of those who were served who ate less because there wasn't enough money for food. So these were real issues that, again, people were already teetering on the edge. They were already vulnerable, but COVID made them almost fall off the cliff. So now I kind of want to talk a little bit about strategies to address health inequities and what we're doing specifically to work to advance health equity. Community engagement, I'll talk a little bit more about that. Home visiting and care coordination, patient navigation, telemedicine, and multi-sector partnerships. So as it relates to community engagement, research shows that lack of insurance is a strong, statistically significant predictor of women not obtaining recommended mammography screening. In addition, studies show that women who have no primary care provider and not have visited a provider within the past year reduce the utilization of mammography screening. So as such, our outreach strategies are designed to increase hard to reach, underserved women's awareness of screening and diagnostic services offered through us and essential partners. This is an example of Northside Hospital, their mobile mammography unit, but this is a strategy in a way in which we can provide essential preventive screenings to those without income, insurance, and ability to pay. But these are essential partnerships. I'll speak a little about home visiting. Again, our program, our prenatal home visiting program for pregnant and postpartum women. We are one of 6 federally funded Healthy Start grantees in Georgia that are in urban locations, rural locations that are charged with providing home visiting to pregnant and postpartum women. We all, as Healthy Start grantees, serve 700 moms, dads, and infants a year, providing case management, linkages to prenatal care, and linkages to needed health and social services to make sure moms and babies and dads are healthy. But they're also state-funded home visiting programs, and home visiting and care coordination is an essential strategy to address health disparities. Patient navigation. Breast cancer, as an example, continues to be one of the leading causes of death for women in the state of Georgia. Sadly, the mortality rate of Black and Hispanic women is higher than that of white women due to a myriad of risk factors. To compound the problem, uninsured, underserved, and minority populations with limited access to healthcare are even less likely to utilize screening services and preventive care in general. So to address these barriers, evidence-based patient navigation is an essential strategy to address health disparities. Patient navigation can help link patients to care, decrease barriers to patient care, do things such as reminder calls and follow-ups and visits, and increase access through things such as mobile mammography units. I've already mentioned telemedicine, and COVID has taught us that telemedicine can be very successful. And as it was mentioned before, internet can be a problem, technology and internet issues can be a challenge. And so using the phone is also a very, very successful strategy. And we found that with our low-income populations that while there were internet and technology challenges, that there were also great opportunities because you avoided barriers such as lack of childcare, lack of transportation, for folks who needed to balance school and work schedules. And also just for the safety of staff and volunteers, that telemedicine continues to be a successful strategy. And so whether it's a matter of in-person care or telemedicine, we've learned that it's not an either or, it's a both and. It's essential. Lastly, I'll just say multi-sector partnerships is something that we believe in firmly, that we cannot do this work alone, that it takes a collective effort, again, of the FQHCs, of the private sector, of faith-based institutions, and non-traditional partners to do this important work around eliminating health disparities. So for an example, some of the work that we're able to do because of partnerships is the mental health piece. We don't do mental health. We rely on Odyssey Family Counseling Services to come in and provide the mental health. We also use volunteers. So we have a volunteer psychiatrist. We're very fortunate for that. And then we also do some very non-traditional work to address mental health because of lack of providers. So we try to innovate and do things like virtual yoga and art therapy and all kinds of things that really resonated with our clientele. But then multi-sector partnerships also help to solve the big problems, right? Like how do we try to get women in that postpartum visit within 6 weeks of delivery? Or how do we work together to address maternal mental health? So again, it's having that big tent and bringing multi-sector partners to the table to address these big challenges. So in conclusion, I think I'm concluding. Yes, in conclusion, we believe that health must be defined broadly and include multiple approaches to improving family and community wellness, that evidence-based and community-driven approaches can help mitigate the social determinants of health and health disparities, and that strong partnerships are critical to creating systems-level change. I thank you so much. Thank you for your time and for your commitment to the health of all Georgians, because it truly takes all of us to do this hard work, but together I know we can do it. Thank you.
Thank you. We have questions? Appreciate your work.
Oh, thank you.
Okay.
Sorry about that. Good to see you and
Good to
thank you
see
for
you
all
too.
your work. One of the questions and one of the things that we found during COVID wasn't just the lack of food, but it was the lack of access to basic things like period supplies. We've got an issue in our communities of color dealing with period poverty and menstrual equity that we really do need to start focusing on and collecting some data on that. I'm not sure if that was one when you were sampling about food, if that was an issue that surfaced or bubbled up.
I'm glad you mentioned that because we also provided hygiene and personal item kits during COVID, and we still actually have some supplies. And that was something that was very appreciated. And I didn't know that either, that was going to be something that was a big value. So between the personal hygiene items that we were able to distribute, also infant care supplies, I missed that piece, but that was a big piece because there were some issues with even delays in actually being able to access WIC services in the very beginning of the pandemic, those who were eligible for WIC services, but for just barriers in terms of being able to, phones being answered and being able to get appointments and things like that. So we were, so yes, I think that's very important. And then also, women, we need to be able to have our dollars in our pocketbooks just as much as any. So to have that extra expense is always going to be So, I mean, we want to have our money in our pockets too. So we want to, those are extra expenses that if there are opportunities for those cost savings to happen, I think it's very important.
Yeah, thanks. And just a follow-up is Madam Chair has been, working tirelessly through the Women's Care Act that helps incarcerated women with these kind of issues that are surfacing. So all of the services that you are dealing with on the inside, we've been trying to fight this for people and women that are behind bars. So thank you. And I do believe in collaborative partnerships and look forward to continue to work with you.
Thank you. Thank you so much for all the work that you're doing. I appreciate it.
I think I just got a thing that the governor of North Carolina is signing a bill which will be about shackling pregnant women and was modeled on Georgia's legislation. So apparently, pardon? Well, I know. I mean, that's one of the problems we have in this state is getting people to follow the laws, all the different kind of laws. I hope there's been a decrease in it. You don't think so?
No, I know for a fact. But again, we have a prison accountability act.
Right, that they're looking at now. Okay, so 2 steps forward and 1 step back. Okay. Who's this? Okay, so, well, we're trying to work on it on like this. And I will tell you that often people think it's just women in rural areas. They do not get prenatal care. There is now a young medical student, African-American, accepted at Mercer, and she's at the Savannah office, who before she was accepted did a study on prenatal care and found that 5,000 mothers in the metro area received no prenatal care before their deliveries. So I am real proud that Mercer accepted her and look forward to seeing her out and practicing in Georgia in a few years. And she is leaning heavily toward maternal OBGYN and was already, making her mark before she got accepted in medical school. So we do definitely need to work on making sure that women get in prenatal care, which then leads to less maternal deaths like that. Thank you for attending. Thank you very much.
Thank you.
Okay, and last but not least, Dr. Marlon Harris with New Life Community Ministries, which is a faith-based organization. Mr. Harris, or is it Dr. Harris really, or no?
Either one.
Mr. Harris, either way.
Either is fine. Marlon is just as good.
Thank you for coming.
Thank you all for having me here and for being able to listen to what you've heard throughout the day. It speaks volumes of this committee and volumes of this team that you show such interest in these issues related to health and health-related disparities. I want to give a very strong thank you to Representative Schofield for inviting us all here and coordinating to make certain that this took place. Thank you so much. She's done so much work, even with our center, part of its genesis 20 years ago. And just an honor to see all that has happened with you and that's taking place. So proud. I am here representing New Life Church and New Life Community Center. I am the pastor of New Life Church and the president of New Life Community Center. And we are deeply committed to health concerns and health issues, especially in the African-American community and in communities of color, where there are great health disparities, as you've heard over the course of our time together today. We are so committed that we hired a PA to serve as our center manager because we wanted to make certain that health is at the forefront of what we do. We've developed partnerships, very effective partnerships with organizations like HEAL Collaborative and Dr. Mosby, as well as AstraZeneca for many years. Morehouse School of Medicine has been assisting us quite frequently with health screenings and a host of other activities that support overall health in our community. It is quite important. Today, I would like to address health disparities in racial and ethnic minorities. I'm coming to you on behalf of over 20,000 clients and constituents who have been serviced in some capacity at our community center in the past 5 years. A small picture of who these human beings are. Many of them are chronically ill, yet currently undiagnosed. They are uninsured, underinsured, and many are at the mercy of state and federal medical care and aid. Among them are the mentally ill, the HIV positive, the hypertensive, and several are struggling with obesity and lack of healthy and proper nutrition. They are single moms and working dads, school-aged children, who only eat what's offered by their school lunch cafeteria and depend on subsidized lunch for their daily nutrition. These are men and women who are severely unscreened for major diseases like clogged arteries, hypertension, diabetes, kidney and renal diseases. Not only are they unscreened, they are often uninformed about proper nutrition and healthcare, and several do not have primary care physicians. Many of them may never see a specialist for diseases that will often go untreated or improperly treated. And yes, many of them have made terrible choices in their lives that have netted devastating consequences. The challenge that they face is that their choices are overtly seen, but the stories and reasons behind those choices are often never seen unless we're willing to step into their experiences and walk a mile in their shoes. They come from histories and experiences that, if undergone by any one of us, we most likely would have made the same choices. And for many of us, maybe even worse. These are the clients of our community center, members of our church, members of our community, members of our neighborhoods, and their friends that we see every single day at our center. But that's not all that they are. They are moms and dads. They are young, bright, and aspiring children who are loaded with potential and dreams. They are grandparents who are the sole caretakers for their grandchildren. They are talented musicians and artists. They are young scholars waiting for open doors and accessible opportunities. And in more ways than many of us are willing to even accept, these people share our common humanity and are members of the human family, just like you and I. So I'm here to advocate for them today. I'm here to be their voice because they do not have the opportunity today and may never have it in the future to speak for themselves. I want to be an apologetic for the marginalized and a defender of the poor. But more than that, I want you to be one far more than me. You've been entrusted with power and legislative influence. And we are here today to call upon you to leverage your power and influence for the poor and the overlooked. I will do my best to speak for them, but they so desperately need is for us to use our power to speak to them. Allow me to introduce you to just one of them. Her name is Brenda. Now, to be clear, she is not an actual client of ours, but her story is a composite of the real life experiences of hundreds of women just like her. She is a single mom and working a job, barely making minimum wage. She comes from a very difficult childhood, which made getting a high school diploma quite difficult for Brenda. From an abusive upbringing by parents ravaged by alcoholism and substance abuse, Brenda has been out on her own since she was a young teenager of 15 years old. Brenda has never seen an OBGYN. She's never had a pap smear or been screened for any illnesses that she is at high risk for. She became pregnant at 17, and without any coaching or role models, she does her best to be a mommy for her children. Brenda works during the day, cares for her children in the evening, and tries her best to study for her GED at night. As you can imagine, Brenda doesn't have health insurance, and her children do not have a pediatrician that they see on a regular basis. Health care for Brenda and her children consists of late night calls to the emergency room when illnesses arise that mere time and hope will not resolve. What is Brenda asking of you today? She is simply asking for equal access to quality health care for her and her children. She wants to have the opportunity to have a primary care physician And should her health or the health of her children decline, she would like to be able to see a specialist in the hopes of prolonging her life so that her children are not left without a mother. Brenda would like to be able to afford the prescriptions that the doctors are prescribing and not be forced to skip them because they cost more than she makes in an entire week's worth of work. Brenda is paying to live in a world, she is praying to live in a world where her children share the same access to health and health care as children who live on the proverbial other side of the tracks. I could say more about Brenda, or James, the recovering addict, or Ron, the single father of two, or Mary, the custodial grandparent of three children, and the list goes on and on. So what is our responsibility to them? Or what is our responsibility to them and to their health? To overlook any of their medical needs or to not remove barriers to their health care is a significant injustice. A friend and member of my church reminded me last night in an email of a quote from Dr. Martin Luther King when he spoke at a convention for the Medical Committee for Human Rights held in Chicago in March of 1966. Dr. King said that of all the forms of inequality, injustice in healthcare is the most shocking and the most inhumane. Healthcare injustice has been a prickly thorn in the side of our country since the days of slavery and Jim Crow, and we're still advocating and fighting for it today in the 21st century. In 1964, the aforementioned Medical Committee for Human Rights was formed for the express purpose of traveling to city and rural municipalities of the South to provide medical care to poor local communities as well as civil rights workers who couldn't receive adequate care in the segregated South. Today, we are more than 50 years past segregation, yet new forms of healthcare discrimination has forced us to continue having the conversation about healthcare inequality and healthcare disparities. For a moment, let's consider some of the current data on disparities specifically related to healthcare issues like hypertension and cardiovascular disease. And then let's address the socioeconomic factors, also known as the social determinants of health, behind these disparities and their impact on the overall health outcome of poor and marginalized communities. And finally, we will consider some practical solutions on how we as community and social leaders can address these disparities. Health and overall wellness have improved for all Americans over the last 2 or 3 decades. While it is true that our overall health has improved, there is an undeniable gap in the quality of care for individuals and families of differing racial and socioeconomic backgrounds. And since the 1960s, according to Marion F. McDormand and T.J. Matthews, in their comprehensive article, Understanding Racial and Ethnic Disparities in the U.S., which was published by the U.S. Centers for Disease Control and Prevention in 2011, there's been an ever-widening gap in mortality, white versus Black, driven mainly by cardiovascular disease, infant mortality, and illnesses related to obesity. African Americans have more hypertension, diabetes, obesity, chronic kidney disease, end-stage renal disease, heart failure, premature heart attacks, and increase in deaths from strokes than nearly any other subculture or ethnic group in the country. These chronic illnesses are driven by the overt disparities that are present in our healthcare system, as well as our social and communal infrastructures. These alarming disparities have persisted and even increased over time, suggesting that not all racial and socioeconomic groups have benefited equally from the healthcare strides that have been made by medical advances. In July of 1964, Martin Luther King looked over the shoulder of Lyndon Johnson as they addressed socioeconomic disparities in access to public accommodations and basic public facilities and institutions. And the civil rights legislation was a landmark piece of legislation that promised the possibility that all Americans, regardless of their race or ethnic origin, would have an equal opportunity to the institutions that allow for a better, equitable, and healthier life. But as we've gone forward, specifically as it relates to health, probably more than biology or genetics, the social factors that the civil rights legislation was initially intending to mitigate, now they have to be addressed, specifically social inequities as it relates to the disparities in health, healthcare, the overall quality of life in America, as well as in individual states, such as the state here in Georgia. If you look at some of the latest data as it relates to cardiovascular health, for example, published by the government's Office of Disease Prevention and Health Promotion, as well as the Office of Minority Health, you'll see that African Americans have more early onset and premature hypertension, death from heart failure and diabetes-related diseases, higher rates of deaths from strokes. The critical fact that must be mentioned here is that these are not driven as much by biology as they are by the social determinants of overall health and well-being. Such social determinants are things like communities where people live, access that they have to quality healthcare facilities. We mentioned about our FQHCs, but the distances that they have in many communities in rural areas make it almost impractical for many individuals who need the care and benefit from FQHCs to get that care and benefit, just simply because of the lack of ability to get to many of them. These determining factors, not just where they live and the quality access they have to healthcare facilities, but the ability that they have to afford healthcare coverage, things like where they work, the types of industries that they work in, their salary range, healthy food choices that exist within their communities. These are the various factors that affect the outcomes of the health of any community, regardless of their ethnicity, their race, or their genetic predispositions. In far too many places within our state, many Georgians are living in what is called a food desert. It's not that there aren't places to eat, but there aren't places to eat healthy or to eat well. When you work long hours, care for children who are in your home without the luxury of being a stay-at-home mom, you are forced to feed your family with the options that are most available in the community that you live in. Many of these options in poor, underserved, and marginalized communities are sodium-filled, processed, cheap foods that lack any solid nutritional value at all. When this is the diet of your family, health conditions are bound to exist. The vicious cycle that this creates is that the food that we need for life simply isn't available in poor communities, and the food that delivers illnesses and diseases is readily available. However, the economically poor who subsist on these unhealthy food choices can't afford proper quality health care when they're sick, which increases the chances of chronic diseases and eventually death. We hear about the disparities in the death rates that are not just affecting or connected to COVID, but are connected to so many other diseases. And the question is often, why is it that people of color seem to be dying at higher rates in many diseases than others? It's not because of genetics. It's not because of biology. It's not because of the genetic code. It has a lot to do with the environment and the culture upon which many of these individuals and communities of color live, where they work, how they live, the places that they work, the industries that they are forced to work in has a lot to do with the overall health of any person, any family, and any community. They are not dying because of genetics, but rather because of the cycle that their socioeconomic status has imprisoned them to. We know that race and even ethnicity are social terms without really true biologic factors. Nevertheless, we don't address these social determinants: universal health care, access to a primary care physician, appropriate referrals to specialists. If we don't address these factors, we're doomed to see the disparities persist. The Institute of Medicine, as far back as 1960, suggested that there were real disparities in cardiovascular care. Now in 2021, we have not seen adequate progress socially and legislatively to address these concerns. It doesn't mean we haven't seen any, it just means we haven't seen enough. In fact, the social determinants of health probably have more of an impact than any biology or genetics as it relates to race and ethnicity and the health outcomes of many chronic lifestyle diseases. Now, if you look across the state of Georgia in both heavily white and heavily Black populated areas where there are poor economic and social conditions, you'll find higher rates of cardiovascular disease, including heart attacks and strokes, as well as diabetes and renal disease. Not just Black communities, but poor communities where either Black or white or any other subculture lives. It is important to note that in these areas, you have a large number of persons who are uninsured. This uninsured status quite naturally leads to poor health outcomes. The reality is that people who cannot afford medications, primary care doctor visits, and treatments by specialists simply will not have access to quality care, and many of them do not have the confidence in the access that they do have. Now, without question, one realistic delegation of this population is a large proportion of African Americans, Latinos, and people of color who live in these poor and marginalized communities. In a real sense, health and medical disparities is not a race problem. It's a social problem. Whether or not we choose to address it and correct it is neither a medical nor a social problem. That is a moral problem. It is morally wrong to have the power to correct an ill that is plaguing society, yet because of political or social inconveniences that your actions will cause, we simply choose to do nothing. The solution to the disparities that we've heard today are not merely a medical one. The observed disparities that countless studies have been published on are not simply explained by race or income or even healthcare access. This issue of health disparities must be addressed at the fundamental life level of socioeconomic inequalities. Until we develop policies and strategic legislation aimed at leveling the economic field for all Americans, we will not be able to mitigate and reverse the disparities that we see in healthcare. Whether we're talking about infant mortality rates, women's healthcare concerns, or general preventive healthcare measures, the challenge we face is developing a public health strategy that includes a socioeconomic component. Where there is low and impaired socioeconomic health, this will result in low health outcomes for the people who live in those conditions. The hard truth is, your zip code can be more important than your genetic code when it comes to your health. When the entire community is unhealthy and your family and social dynamics point toward a low health reality, the chances are that your life expectancy and the life expectancy of your family diminishes greatly. The Healthy Communities Organization, which is an organization that tracks the connection between community income to healthcare access, reached the conclusion that life expectancy goes down by more than 10 years, not only between races of white and Black people, but also between economic conditions of the underclass and the middle class. By simply raising the quality of life for a community educationally and economically, you can add approximately 10 years of life expectancy to that community within the span of one generation. Now, we've diagnosed the problem today and we'll continue diagnosing the problem as we move forward. We have discussed a little about what we can do to remedy the problem. What is left now is to discuss where we must get the motivation from to do the hard work in confronting this issue with an unrelenting determination. And I think being present here today certainly shows that motivation. What motivates any of us to do anything difficult, whether or not we believe it is right and necessary to do so, is our belief. Our belief, or more specifically, our faith, must ultimately be our guide. Socrates expressed this reality when he discussed how the priority of right action should supersede the convenience of pragmatic satisfactions. It is more imperative that we do what is right than it is that we do what is pragmatic, or even practical for that matter. This is what led Gandhi in his revolutionary thought, what gave moral convictions to both Martin Luther of the 16th century and Martin Luther King, his namesake of the 20th century. They were unusually burdened by what was the right thing to do. You can't discuss any noble civilization where the rights of the poor and the disenfranchised were overlooked or ignored. No civilization with any nobility ignores the people that are poor and weak among it. It is how a civilization treated the weakest among them that determined the moral health of that civilization. I'd like to think that's true of our current society as much as it ever was true of any past society. Whether you're considering a Greek philosopher or a German theologian like Dietrich Bonhoeffer, who died for the causes of a people who were systemically disenfranchised and erased from every legal provision the nation afforded them, or if you're considering the hero of the Christian faith, Jesus Christ. Here you have in Christ the quintessential witness to the power of doing what is right for those who are powerless and underclassed by all social definitions. Jesus demonstrated that we are to bind up the wounds of the sick, that we are to care for them with our abilities and resources when they are unable to care for themselves. He never taught that we are to dole out handouts, but that we are to write them into the social construct of our times and leverage our power on their behalf. His parable of the Good Samaritan was not a suggestion, but it was an imperative of what it means to live in a just and equitable society. His miracle of choice was to perform a healing for someone who was ill and infirm. And this was not by accident. He elevated the cause of the sick by healing the sick. He elevated the needs of the poor by speaking to the poor. He made care for the sick a sacred task, and he loved the poor with a holy virtue. The scriptures record narrative after narrative that include the words, and he healed them all. He was concerned about health. If concern for the sick and disease consumed so much of Jesus's ministry, and we all hail him as the purest picture of justice and character, then shouldn't care for the sick and disease matter to all of us as much as it mattered to Christ? If you look at the standard that Jesus set by his attention to the sick, then to not care for them would be categorically unchristian. To allow the poor to go without health care or access to affordable medication wouldn't that also be categorically unchristian? We can debate about what that looks like in our 21st century society, and I believe we must debate about it. We must discuss it and strategize to fix it, because it's not just a political and medical issue. It is a moral issue. So in closing, I'm encouraging this body to spend your time doing what Jesus did, which is what you've been doing this morning. You spent your time listening and hearing the causes of the poor. You spent your time binding up the wounds of those who cannot speak for themselves. And for that, I think we're on the right path of closing the gap to many of the health disparities that plague our community and our culture. Thank you so much for the time.
Thank you, Dr. Harris. I'm sure that you have a rather large church with your ability to preach and certainly deliver a message. I would tell you that we're not just on the path, but we have been doing things within this state and this committee to do many of the things that you are suggesting. When you did your person that was your composite patient, I would tell you, and I hope that you will tell the people, especially since this went out over the internet, that we have and have had for a few years the Good Pill Pharmacy. We are the only state, unless somebody has done it lately. This is where we recapture good medicines, and people can go online, and if they can't afford their medications, they are sent free or for $1 or $2 across our state, mail order at that very little charge to people. In fact, more people need to know that this Good Pill Pharmacy, which is not something you walk into. It is strictly mail order to people who need our help and the medications they carry. That children and the children are covered by Peach Care and our Medicaid program that this state has especially for them. We passed a bill this past session that past this time next year, it'll make it easier where people go when they sign up for food stamps and they're in the situation where they need them, their children will automatically, without another application, be signed up for our program for Peach Care. Because often we have over 200,000 children that are eligible to be covered in the state, but for some reason they are not being signed up for Peach Care. We don't know why, and they're trying to reach them, and they are eligible and will be covered for medical care. So, we're working on it on telemedicine and public health. But some of the things you're talking about, it's not a lack of moral want to do it. We have counties that have 3,000 patients or less, or people that live in those counties. And you talk about having to travel. Those will not support a physician. So, they're going to have to travel. You want a family physician? They're not going to live in a county that has 3,000 people. And they don't have access, and the PAs and the nurse practitioners are not going to go there either, because they want to have places where they can go to the theater or to have, plays and so forth. So we have structural problems in the state with the loss of people in our rural counties that are making it more difficult, but we're working on it. There is a public health system community or public health clinic in every county in our state. We have tried to bring them on to where people could go in there and with telemedicine, connect with the specialist. But each of those public health units are run by a county health department. And they get to decide what happens there, even though the state puts money in them. And often they are against doing something like this, or it's not their priority. So, and we tried to do the Medicaid, as we said, we're working on it. And I just wanted, since this is going out, for you to know that we're not sitting by, and certainly serving the underserved is certainly a priority of mine, because I believe that one of the things as a legislator you should do is do what's right. So just so people listening would know that the state is not sitting in, this administration is not sitting by idly, not trying to make a difference, just like we passed the bill to try not to have women shackled. And then you hear that it's not being enforced. We will go back and look at that again. So we are trying to do just like you are trying to do. But part of the part we're going to need is to change some of the moral attitudes are going to have to come from the church. It is not something that we can legislate. It either comes from within or from the direction and the learning for pastors like yourself about the moral need to help others as we would want to be helped. So I've lit up the board. Representative Sharper.
Thank you so much, Chairwoman, and thank you also, Representative Schofield, for this day. I think it all starts with accountability, totally. The accountability for one, and we have to put a little disclaimer up here, but a lot of the accountability comes from, I would say, on a federal government and sometimes a state government level. We talk about the numbers and the data, and you can probably go in every community and see most times in your housing authorities that there were a lot of those people live in that area. Did you know that every adult that has diabetes, high blood pressure, obesity, renal failure, that they used to be a child? Y'all do understand that, right? I say this, most of these areas that we're talking about where these children live, everything starts as a child. I wish in a perfect world that when people do receive food stamps, housing, things like that, that we can hold the parents more accountable They have different little community centers. Hold them more accountable and say, okay, you see these problems that we've had with the health issues with adults. If we don't start and change that cycle of healthy eating with these kids, if you're getting money for it, you can go in the stores and buy healthy food. But if you're ignorant to that fact that we're in the situation we're in today, I don't care if you expand Medicaid, give everybody free health care. But unless you get a plan and get aggressive, it's time for us to stop doing what we've already been doing. We're not getting any different results. So we need to be more aggressive, I think, in our youth, in our kids, to put that in their mind. Because if you're taught as a kid to be more health conscious, to take some vitamins, maybe to do a little bit more exercise, then you're going to become that adult that's going to be aware of that. You're going to be that healthy adult. So we can have motivation to do all of this and have all the hearings that we can have, but we must have a disciplined focus of what we're doing.
I completely
I'm
agree.
excited to be here. I'm glad we're here, but at the same time, we got to formulate a plan that is going to work, that we can watch over time. But if we're talking about making a difference, we have to put a little bit more effort on our preventive side. And the churches, when you're going out, sometimes giving food to these different organizations and these different housing projects, let's see if we can collaborate between our medical partners, our government, and our churches to say, let's focus on helping these parents who haven't been taught. That's the cycle. You have parents now, a lot of the single parent moms and people that are raising these kids, but their parents didn't raise them because they're in that same cycle. So until we break the cycle and do something different, we're gonna be in the same situation, throwing more money for chronic illnesses and problems versus putting a little bit more here on the preventive side. But in the whole system, you're gonna have the preventive, we're gonna have the ways that we can intervene, then we're gonna have the ones that are gonna get terminal. But we just need to all work on this system to start and putting a little bit more on the preventive side and working with these kids so they can be healthy adults. But I thank everybody for being here, but let's push each other to be more aggressive, more action, less talking. So thank you again. I see Dr. Nina there. Where is she still here? All right. But thank you. Last time I saw you, you were doctor of the day for us. But we met 8 years ago, me and your husband, everybody, and I knew your heart, and that's how we met, of you giving your heart and giving your finances and things like that to this community. So it's great to see you here, and I thank God for you, and I thank God for all of you. Disclaimer done, okay.
Representative Schofield.
Okay, well, thank you, Pastor Harris. It's been a long time since we have been in a room together.
Sure.
Just a couple of things. I want to echo a little bit of what my colleague has said, but also, you know, and I know you will get this because you taught me well about acronyms, but the distinction between the socioeconomic inequities and social determinants of health, your nail on the nail in the coffin is really our job here is to marry the two with the political determinants of health. We do have the power to change some things. So as Madam Chair was talking about, that's the fruit of what we've done. What we have failed to do is address the root. And that's what I was hoping that these conversations about inequities and disparities that we've done, the programs, the good pill, that's a fruit issue. We're still not addressing in this state the root issues. And until we get that, and I'm going to echo what my colleague has said, you know, it is this whole thing about oath. And I've been worked on that for a while. Oversight, accountability, trust, and honesty. When we take an oath here, those are the things that we ascribe to, and how we execute that is through the programming pieces on that. But until we recognize that it is not just the socioeconomic inequities, but also the environmental health triggers, that we're talking about soil, water, air. We need to look at agriculture and the toxins that are going in these food systems. We need to address the lead and all of the antiquated systems in pipe. We need to look at the air quality that's influencing asthma. Until you start to deal with these, this is what we do. We are the policy makers. We influence the political determinants of health. So the policies that we are not doing and the equity that's not coming across the boards feeds into your social determinants of health, which is why, again, today's hearing and collecting this data is important. A first step in taking an action, because we can gloss over everything and say we're doing well, but we in this state is still last in a lot of key systems. Yeah. So we can do better. We will commit to do better, but we need to write these policies that will help you in the church. And then I would make the ask that you have always been on the forefront of health. What people don't know really quickly is that when I got diagnosed with lupus, I was at your church and I'd lost my job. I'd lost all of my resources. I didn't tell anybody. But when I went and put my story in the newspaper and said, if you have lupus, meet me at New Life Baptist Church at that time, 65 people showed up. And I was that story. My daughter was a young, we lost all our resources. I had to choose between feeding her and getting my medicine. My medicine was supplied to me by friends who had friends that were family members, were physicians. So these stories are not stories that are, this was your colleague.
And they're very relevant.
And they are very relevant. And you've been on the forefront. We've got to get the churches to start connecting with the policymakers and put a demand on us for these political determinants of health to be addressed, and not at a fruit level, but at a root level.
I would agree wholeheartedly. I think that it's a complicated issue and we don't take that lightly, but I think that we run the risk of feeling like we've succeeded or solved it. If it was solved, it wouldn't exist. The fact that the issue exists says it has not been solved. We've made great strides. We've done extremely well, but we've not done enough. There are people who are experiencing significant health disparities, like my Brenda, but that Brenda is a real person with real issues, much like Representative Schofield was at that time. To say to her at the time, well, we've made all these other programs and we've done all these other things, and why won't you take advantage of those things, is to ignore the unique factors that was in her situation that's different than anybody else's situation. Health is a person by person, case by case concern. It's not something you can gloss over with one pill. It's a case by case concern. We have the power to do what we've done and to do more. And I think that's what we are trying to express today.
Thank you, Madam Chair. I appreciate you being here. Thank you very much for that. I know there were just many great things and many great comments made. I know Representative Sharper talked about discipline focus and collaborative efforts, certainly key. And so I won't go in there, and did it passionately, and I appreciate that. But one of the things that has come up a good bit, and I know Representative Schofield kind of brought this up a little bit, but the need to know. She stated that the state of Georgia is still last in many areas. And one of the things that I have found repeatedly over and over, and it comes into some of what you said, which was we can solve this. We have educational needs and we have the economic needs. And one of the things that keeps happening when I keep getting involved with folks that are really struggling is that they don't know a lot of what's available. And that's not just the folks that need the help, it's the folks that are giving the help that don't even know what's available in the state and what we have done as a state. And I would like to say again, which is why every single time the FQHCs give their presentations, I get so excited. Because again, over and over and over, and I'll use Representative Schofield's term, the political, complications of all of this. Over and over and over, sometimes we want to get in our corners. So we won't talk about the FQHCs because we want to talk about the uninsured, which is funny. They actually meet in the middle. You know, we need to get them back together. The fact that we have the ability, and Chair Cooper has done some amazing things, especially with expanding the Medicaid for the postpartum moms and that kind of thing. She's done a lot of work and a lot of focus on that. We need to make sure people know what's available to them. One of the things, other than the FQHCs that I love, is that the Georgia has the Hope Grant Scholarship Program. So when you talk about education, we've got 26 free tuition programs in Georgia in the technical college system. Do you know that almost nobody knows about that? Almost nobody. So we're talking about kids and we're trying to get them out of these sort of this cycle of poverty. And I still have educators and school leaders and church leaders that don't even know that those programs exist. And this is where we should be taking a lot of our kids and pushing them into these technical programs. And some of them are aerospace. Some of them are childcare related. There's 26 of them. They're amazing. And that opportunity is there and people don't know about it. So the word collaborative that Representative Sharper used, I cannot say that enough. But we don't just have to educate the folks that are in need. We've got to educate all of us. We, as the leaders in the community, have to know what options are out there. We have to know that we have the 126, is that what they said? Public FQHCs, however many of those were. 200, okay, 200 some. Then every county has a public health office. That Medicaid is available in Georgia, that from 100% to 400% of the federal poverty line. And this is something that also really has gotten to me, that from 100 to 400, you qualify for the federally subsidized and significantly subsidized health insurance programs. So we really shouldn't be having the big uninsured conversations. We need to figure out who those people are and why they're not insured. Of course, our waivers are still being worked on, but that's the other piece. There's a smaller portion that will fall below the 100% that didn't qualify. And we've worked on that and we passed legislation for that. So all of those things are in line. And I just want to make sure that we really continue to focus on the education. We need to know, we need to make sure that the folks who are in need know what their opportunities are. And that seems to be where our biggest weakness is. And I do appreciate all that you're doing, obviously in your church and your community center, because you are engaged. And we just gotta find more folks that want to jump up and kind of work as a team. And we will do it at the state level. I know for a fact, I've sat with Chair Cooper for years. We want to do it at the state level. It does not always trickle down appropriately or the way in which we had hoped. We need to get it there.
Well, we hope that it can do better. Education is important for both the individuals who need to know on the side of the poor, but also education on the side of the power for those who are in power to know the unique factors involved in the lives of those who are poor. If the problem was solved, we wouldn't be discussing it. The fact that we're discussing it says the problem is not solved. We still need to talk about things like uninsured and things like access to the programs that you've already done. Both sides need to be equally discussed and equally valued. So thank you. Thank you so much. Thank you.
I think that's what Representative Lawton are both getting at, that both sides, Pastor, need to be equally discussed.
Yes.
And so that is what we were thinking.
Yes.
Right, can't leave yet. Representative Douglas.
Oh.
one more after him.
Oh, I'm sorry.
Go, Demetrius.
Thank you, Madam Chair, and thank you for putting this together. This is very heartfelt to me. I want to thank all the presenters today who came down to give our side of the story, the disparities in non-affluent areas, places that we represent as African Americans and Latinos and Asian, the people who have been left behind, so-called left behind. We live and work and play in a state that educates some of the most brilliant minds across the United States. We have higher education facilities here in our state that's top class in the United States, and they take their education from here, Georgia, and take it back to their home state and become experts in whatever field they're in, but they were educated right here in the state of Georgia. I commend you for calling this, and I hear the edge and the uneasiness about discussing the disparities on one side. But I just wanted to say this because it's touched my heart, that when you hear somebody else's plight, it doesn't slight your plight. We don't have the other side in the room when the decisions are making to hear these disparities up front. So when we do make decisions for our state that encompasses all races, it's not one-sided. But when you have people in the room that don't look like us, that don't look like Asian, making decisions for the state, it's always going to be tilted one side. And I'm trying to, Madam Chair, I'm glad you had this to hear the disparities in these communities, because we represent, some of us have more in their communities, but since we are them and we come from them, we hear it a little bit different than your side hears it. But if you hear it from our side, it's not to attack and say you're not doing anything. We just want to tell you how we feel on this side. Okay? And that's why I passed the recess bill, to accommodate and catch it early in our childhood, to affect them cognitively in their minds and their bodies, to have recess. We live in a state that's cold 2 months out of the year. And we can't have recess to help the abilities in our children, to help obesity in our children. And we needed even more coming out of this pandemic. But I want to applaud, I'm not going to overcook my grits up here, but I just want to applaud the people to come to tell the other side of the story. And it's not to attack them, it's to listen and understand and get educated about what's going on. Not saying that we're not doing anything, we can be doing more.
We can be doing more.
You have a good way of
Yes,
putting
sir.
it, of course. You know how I feel about you. But it doesn't always feel like that it's not an attack. Okay, Spencer, we're going to let you end this.
This will be short. And I do say folks, but I've never said overcook my grits. That's a new one. I'm going to have to write it down. Hey, look, really, I just want to say thank you to the presenters as well. And Madam Chair, I want to point out that no matter what the political pressure that we face, that you have always been a leader into helping the citizens of Georgia get access to care. And you always seem to care. And I think that's shown in putting this meeting together in the off season, that we came here to learn about the things that we may not have learned about otherwise. So thank you for your leadership with the work that you do as well.
I too appreciate all the presenters. I am pretty passionate about, as you can tell, about caring for people, and have spent my time down here trying to move forward. That we go back, way back to the concussion bills, trying to protect, our children on the playing field and all. So thank you to the presenters. I'd like to say that there's lunch for the committee in room 605, committee, staff, and the presenters that are there. I think, and David, is it you back there in the corner? Okay, join us. That almost takes care of everybody in the room, but as long as they have lunch, I'm going. And I hope you will talk to each other and the different people on the committee. I have to go to another meeting on the Holocaust Commission, so I won't be there. Thank you very much.